everyone! Since you're in the comfort of your own homes, listening to this online science forum, instead of being at the lecture hall of the College of Development and Communication, we are indeed learning in difficult times. But learn we must and learn we shall. This science forum, entitled Pagmamatyag, a multidisciplinary discussion on epidemiology in the time of COVID-19, was designed to deepen our understanding and appreciation of epidemiology and its role in decision-making and taking action for public health. Three panelists will lead our discussion: Dr. Enrique A. Tayag, from the perspective of public health; Dr. Emmanuel M. Luna, from the social science standpoint; and Dr. Jomar M. Trabajante, from the data science and mathematical modeling perspective. We hope that this discussion will allow us to recognize that now, more than ever, we have to work together. And now, more than ever, we must communicate science. I would like to congratulate the Department of Science Communication, led by its chair, Assistant Professor Elaine Llarena, for spearheading this event. I also express my deepest thanks to the faculty and staff of the College of Development Communication who helped organize this event. So again, welcome to this year's first Science Forum.
So now we'll move to our third panelist, our last but definitely not the least speaker. So our next speaker is Dr. Emmanuel Luna. So Dr. Mel is a professor of community development at the College of Social Work and Community Development, University of the Philippines, Diliman. He is currently the Director of Education at the UP Resilience Institute and a member of the UP COVID-19 Pandemic Response Team. Dr. Mel obtained his PhD in Urban Planning at the School of Urban and Regional Planning, University of the Philippines, Diliman. He is a researcher, author, and co-editor of international journals in the field of disaster risk reduction. He has extensive practice in community organizing, action research, participatory monitoring and evaluation, and social environmental impact studies. He specializing in community-based disaster risk management. He has published several papers in national and international journals. So let us now listen to Dr. Mel Luna.
Okay, thank you very much, Professor Llarena, for inviting me to be a panelist in this forum. I know this is a very relevant topic, especially today, when we are now moving from enhanced quarantine to general quarantine and probably to modified general quarantine. My topic for today is about the socio-structural factors affecting public health and the policy implications and challenges. So let's move to the next slide. Early this year, I met a young doctor. It's a graduate of UP Medicine in 2012. And I would like to acknowledge him because this actually is a slide that I got from his presentation about the social determinants of public health. We all know that public health is influenced by several factors, not just the social factors, but including the technology, the status of the environment, the medical conditions, and so on and so forth. However, we are going to focus now on social structure because we cannot deny the fact that the public health system is highly determined by these social determinants. And I would like quote, for example, Dr. Rarely this year, who succumb to those with money can fully pay for out can fully pay for pocket payments, often because they have generous health insurance. However, usually the poor and the lower middle classes can become impoverished to meet out their pockets for healthcare. And finally said, the very poor don't even have pockets. So we'll be speaking today about factors for public health from a social scientist point of view. Okay, next slide. The first structure that I would be speaking about is about um, um, the structure of the Philippine population. As you can see in the graph, still we have a pyramidal structure in which the bulk actually would fall from 40 years old and below. But let's look at the characteristics of the population in relation to the COVID-19. First of all, let's look at the 5 years old to 19 years old, which comprise about one-third of the population. And according to the study in modeling, which my colleague in the UP pandemic team did, Dr. Rabahante and company, they were able to see the interactions of population from different age level. And they said that the younger groups, meaning 19 years old and below, had the greatest interactions in terms of number of people they met, etc., etc. And at the same time, based on the records reported, they've seen that the younger ones are able to survive COVID. Those who were infected by COVID, the younger ones are able to have higher rate compared to the elderly one. And for those who are senior, like me, 60 years old and above, which comprise only 8.2% of the total population, it is observed that uh, though they are elderly, they have also lower interaction, okay, compared to the younger ones. However, when it comes to survival rate, they are the ones who are most vulnerable, meaning once they are infected with COVID, then the probability of fatality is higher. And this is the reason why we have certain policies right now that takes into consideration the characteristic of our population. For example, now seniors are advised to stay home. Okay, unless if you're a senior, you can only go out. Well, also it's your choice. You can go out only to buy your essentials, maybe to go to the banks or maybe to work. However, if there's nothing essential, then it's better to stay home because of the probability that if we get infected, then the fatality is high. Secondly, the opening of classes is delayed because once the classes are opened, then this interaction among the young people would really be increased. And such, the greater the interaction, the greater the probability of infection. And this is the reason why, as lately Secretary Biel said, that face-to-face classes will not be allowed by the DepEd unless there's no vaccine developed. So this structure of the population would affect the policies like that would minimize interactions among the various groups of people. So at the same time, it is also difficult if we have young people going out because they might have a lesser chance of getting infected. However, they can be asymptomatic, the young people. However, once they go home, it is possible for them to infect the senior people staying at home. And that is the danger of that. Yes, the senior people would be staying at home, but if the younger people would be going out and they are asymptomatic, then they can bring the virus into their homes. So that is the more or less the structure of the population and how this can actually affect our COVID pandemic public health system right now. Let's go to the next structure. The next structure is about this one. It's about the poverty pyramid. The According to Arthur Sigmund Bialos, too difficult to pronounce this. Anyway, all my slides have the sources integrated in the slides, the links and the sources. So if you want to look later into the sources of this, then you can go to the links. Now, this poverty pyramid diagram is a useful tool in understanding the complexity of poverty. It recognizes that there are different levels of poverty and that the poor have different needs as they climb the path to freedom from poverty. So we're just speaking here about the poor. This is just about the poor. So maybe you can say here that let's start from the bottom, the ultra poor, the most vulnerable poor, and people who have few, very few assets and very limited chances to earn money. And then you have the subsistence or laboring poor. These are farm laborers, domestic and casual, low-skilled workers who often live in the brink of destitution. They do not have regular, stable source of income. Then you have the self-employed poor people who meet their basic needs by running small businesses and some cottage industries. And then you have the entrepreneurial poor, people living slightly below the poverty line of about $2 a day. They benefit from loans and other creative additional jobs. So this structure shows to us that there are poor people who can really suffer from epidemic like what we have right now. So let's go to the next slide first. In the Philippines, if we look at the poor in relation to the middle class, into the higher class, it's still pyramidal. Okay, so we can see that only about 0.1% really belongs to the upper class. By the way, this came from the works of Mendoza and Peralta, A Nation of Billionaires, Dynasties, and Yayas. Okay, so they estimated that the middle class would be about 25.2%. So that's about 1/4 of the total population, and the rest will actually be lower class, and that would include the poor, the income poor, and the poor, food poor. When say food poor, they have difficulty already in even accessing the food. Now, the problem rises when the inequality of outcomes is rooted in an inequality of economic opportunities. Definitely, all societies have inequality, okay? However, when the inequality is caused by economic differences, then that becomes more dangerous. Inequality of this type can lead to more volatile and less efficient economic system, and the concentration of economic opportunities within the hands of a few is essentially the uneven playing fields that characterize the Philippine economy today. Our poverty level, according to the government statistics, about 28%, gradually decreasing. Of course, some other sectors like the private sector would say that we have higher poverty rate because the basis for determining the poverty situation in the Philippines is too rigid, meaning the amount needed in order for a person, for a family to be out of poverty is so small when other people say that's too unrealistic. Let's go to the next slide. So there's a relationship about being poor, being into poverty, as well as the health sector. And this is from the work of Adam Wagstaff, who came up with a cycle of health and poverty, showing the relationship between the characteristics of the poor and how this affect the poor health conditions, and then and because of that results in diminished income. Poverty and ill health are intertwined. Poor countries tend to have worse health outcomes than better off countries. Within countries, poor people have worse health conditions, health outcomes than better off people. Poverty breeds ill health, and ill health keeps poor people poor. So, pag may sakit ka, mahirap ka magkaroon ng magandang trabaho. Pag wala kang trabaho, kulang ka sa sustansya, pagit ang environment mo, and then you'll get sick. So this is really a cycle of health and poverty. Let's go to the next slide. In this slide, this shows to us the relationship between the livelihood, poverty, health, and livelihood. Okay, these are interrelated, and I will not go into the details of explaining its component of its elements. Okay, but we can say that the livelihood of populations in developing countries are determined by health status and economic status, which in turn determines their social status in their respective communities. Livelihood is a source of income, and loss of it could lead to poverty. Health status affect the ability of an individual to carry out their livelihood, affecting their source of income. Now, these observations, these formulations are actually evidenced by what happened to us because of the COVID-19. We have seen, for example, how we'll be almost 3 months this June 14, okay? Almost 3 months of quarantine, of course, in different levels. But we can see the suffering of most of the people, okay? While the quarantine affected all sectors, all levels, or all groups of people, from the rich to the poor. But I would say that the poor are the ones who were really affected so much. In other words, maiksi ang PC, sabi nga, other people, maybe they have savings, the upper income group, they can have savings and they can have um, um, assets. But the poor, they don't have savings. They live on a daily basis, and therefore, when the quarantine was declared and they cannot get out to earn a living, then you expect them to be affected. I mean, affected economically, socially speaking as well. So they couldn't earn income, and that's why there was a need to give them food relief, to give them social amelioration funds and other supports. And a lot of NGOs, also non-governmental groups, also supported the poor by providing some relief. Because in a pandemic like this, there seems to be a need to balance between the health conditions as well as the economic aspect of the people. As shown in the framework, if the people will continue to be having no income, then that would affect their health condition, that will affect their immunity system, that can even affect their behaviors towards even violating some health protocols like distancing and so on. So there has to be a balancing of this. Now, Jomar mentioned about the job risk, That's why there's the group, the UP group, came up with this job risk because of the need to understand how people from different occupational groups are affected by COVID. So that if there are some occupations that are at risk, then it is advised that the opening of those establishments will not be permitted yet. For example, those who are into personal interactions, like the spa, the parlors, they are not allowed to open up, because that is that has a lot of physical interactions with people. And so with other jobs in which people would really be meeting face to face more frequently. So there is a danger, therefore, for some people who have high interaction in their jobs to be infected by the virus. So there should be a balance. However, if we're going to follow the proper protocol in protecting ourselves, then that is a way of balancing, meaning me being able to meet the livelihood opportunities or the livelihood needs of the people, and at the same time protecting themselves. So we can see already nowadays, the tricycles as tricycle drivers as well as taxis, where they put some in divisions. I mean, some protective measures made of plastic so that they will not be directly in contact with the passengers. Okay, and also restaurants now, okay, they can only avail through takeout and delivery. However, still the this level of economic activities are not enough to recover. So there are still a lot of people who would be who are still in need of economic activities. Even the tourism people, no travels, no recreations are allowed. So therefore, livelihood related to that would definitely be affected. Okay, so we can see therefore that the livelihood, the poverty situation, and the livelihood conditions of the public is affecting the way we're going to respond to epidemic such as COVID-19. So let's go to the next slide. Another condition or another structure that I would like to mention is about the budget. Okay, the budget is also a structure, financially speaking. And for the fiscal year 2020, our General Appropriation Act, and which was signed by the president, this has this approximately about 4.1 trillion pesos. Okay, for the operations of the national government, and there was an increase of 12% over the 2019 budget of 3.62 trillion. Now let's look at the now if we look at the allocation, where do we find here the Department of Health? The first one with the highest budget is the DepEd, and I will not question that. It should be, okay? The next one would be the Department of Public Works and Highway, okay? And then the DILG is the third. The Department of National Defense is number 4. DSWD is number 5, and the DOH is number 6. Okay, and I would really say that the amount of budget that is allocated to health, to public health, is a factor that would really determine the kind of services, the quality of service that we can have. And I'm not going to discuss here the details of the budget of the Department of Health, but I would say that there has to be, an increase in the national budget for health. This should not be number 6. For me, it should be number 2, or not, if not number 1. I hope that with the present COVID epidemic, this will become a wake-up call for the national government to really come up with higher budget for the Department of Health. And I'm sure that Dr. Tayag here would agree to me that their budget should be increased. I would support that. And we can see, for example, as experienced today in our season today, that the national government was caught in a situation where they don't have much money to provide for the needed facilities as well as needed protection measures. Why? Because of limited budget. And then suddenly we still have to have amelioration fund. To be a social amelioration fund that would given to the people. So if our budget, next slide, if our budget is that small, then as I've said, it's going to affect our health delivery system. I borrowed this slide from the Alliance for Improving Health Outcomes. And I'm not going to the details of this, but the health delivery system would be affected. And for example, here we can see that the hospitals which already evolved will have lesser quality if there is lesser budget. But once you improve, you provided them with some budget, then they would have greater chance to improve their services, to hire more people. Actually, there is some perception towards the government health services. First of all, is that it is perceived as low quality. Secondly, is a poor diagnosis resulting in repeated visits. Health human resources are not available and sometimes lacking in medical and people skills. Long waiting time, inconvenient facility schedule, as well as rundown of worn out facilities. I do believe that our workforces in health are very good, okay? Hindi sila basta nurse lamang, hindi sila basta doktor lamang. We are sending our medical doctors and health workers outside, meaning they are very, very good. They are competent. However, they go out. Why? Because of low salary, because there's less opportunities in our country, because they don't have so much support facilities maybe, and all those things can be responded to if the government prioritizes our health sector in its budget. Okay, and for me that's very, very important. If we would like to improve our public health system, then the government should really allocate more money for the health sector. Next slide. Next, here we see here the health workforce. Okay, so there are standards for health. Okay, standard like how many doctors and nurses should be available for given number for the given population. So here we can see that when it comes to doctors, the standard is about the WHO standard is 2.3 per 1,000 population. Okay, that was many years ago. But the Philippines has only 1.1 doctors, and with the COVID thing that happened today, a lot of doctors still were affected and became fatal. And but we exceed the nurses. Okay, from WHO proposes 2.3 and ours is 4.43. We have so much nurses, but many of our nurses also go out. They also migrate to other countries, or maybe they are graduate of nurses, but they end up not practicing nursing. Okay, so with midwives and dentists, our number is not that much. Okay, so as can be here in the slide, Philippines is a major source of health professionals in the world. Okay, and then there's because of their fluency in English and skills in training received, then they are very, very attractive. Even Japan would like to get health workers from us, but the problem with Japan is that they would like to put our nurses in hospitals in which the medium of speaking is Japanese. Okay, so that's very, very difficult. Okay, however, in America and Europe, where the Filipinos can easily communicate with the patients and the staff because of English proficiency, then they can easily be hired. But so far, in some other countries where the medium of where the language is, it's not really we're not familiar with the language, and it's very difficult to send them up there. Okay, so it is said that Filipinos are very compassionate and very patient. Yes, I do believe that. Okay, and then also there's we are also the leading exporter of nurses to the world. Yes, I've said that. And the second major export of physicians. Okay, so we also send a lot of doctors, and of course the socio-economic and political situations do not contribute to retaining are licensed and skilled professionals. So if our medical workers, health workers are going out of the country, what would happen to the public health? It is ironic that we produce so much nurses, but we don't have a single nurse in a hospital, in a barangay. Okay, usually our LGU would have um, uh, the physician, the nurse, the one midwife, one dentist, something like that. Okay. However, at the barangay level, those people operating at the barangay level are usually the barangay health workers. Okay. There was a program before, and I counted that, where they deploy nurses in one barangay, and I had the research before with the DOH, and I've seen how the people were very, very appreciative of having a nurse, at least a nurse, in their barangay. But then, anyway, so we can see here the distribution in the graph. The distribution also of the different health workers geographically. Again, we're speaking of the geographical structure. Where are the health workers? If you can see in the graph, most of them are in Metro Manila. Okay, most of our health workers are in Metro Manila, and then in the next one is in Region 3, Central Luzon, and then in Southern Tagalog, and then the fourth um, is in Ilocos region. Where where are they found least? In Region 4B. These are the island provinces of Southern Luzon, as well as in Caraga region, as the one with the least, actually, the arm. Okay, so even in our country, there's inequitable distribution of our medical people. Of course, the DOA is a very good program for addressing this. They have this medical pool placement and utilization program. They have doctor to the barrios, and maybe to say at this time that the provincial health officer of Pampanga, who just passed away because of COVID, is a graduate of Doctor to the Barrios during the time of um, um, Secretary Flavier. And then we have registered nurses for health enhancement in local service, RN Heals. We have the Rural Health Midwives Program and the Rural Health Team Placement Program. So I do know that the DOH have all these programs, but I said, even if we have these programs, if our budget is limited, they will not be able to put on. Marami dito yung mga job order, mga medical workers and nurses who are on job orders. When the budget is not passed on time, then they will not have salaries. Like this year or last year, also the budget was approved by Congress late, and so those on the job order medical health workers were not able to get their salaries on time. In fact, they were afraid if they will be renewed. Next slide, please. Also, this one has something to do. Again, this slide is still from the Alliance of Improving Health Outcomes. Another structure is the leadership in governance. This has something to do with our delivery system. You know, the Department of Health is one of the departments that was affected by the devolution of services. Okay, so whereas before all the hospitals were under the Department of Health, now with the devolution of health services, a lot these hospitals are now under the LGU, okay? And that is challenging. Why? Due to the devolved setup of the health system, health reform must not only be implemented at the national level, this must also be promoted at the local government level. The problem is when you have a local government unit that is very, very politically motivated, and it is possible that they would neglect the health aspect of his LGU. There's difficulty in coordination between DOH and local governments, often lead to poor policy implementation and poorly functioning referral system. It happens right now in our COVID time. We can see a lot of LGUs. Some are very good, okay, and some are not performing well. And we can also see conflict within the national policymakers as well as the local LGUs. And some LGU executives are very, very active. They're very good in their decision making, etc. And yet some others are not. Okay, so while the devolution is good, if you have a mayor, if you have a local executive, that is very good. But if you have a local leader, okay, who is not that good, he's more politically concerned, who is more concerned about his interests, about his political career, then it would be very, very difficult even to address issues concerning the COVID-19 in his area. Health is not a priority in most LGUs, okay? And then I will not mention names. Health is because of the anti-terrorist bill speaking against the government might be even be considered as a terroristic act. The lack of facilities and skilled health workers at the primary care level. Okay, all barangays now have barangay health center. It's a requirement. Okay, but we still need to develop their capacity. Still need to develop, provide them some equipments. Um, I know some local initiated health facilities were closed because they do not subscribe to some standard of the government. Of course, the lack of health referral system mechanism among the LGU themselves. What we're trying to say is this. Because of the devolution of health services at the local level, at the community level, the system, the implementation becomes more challenging because it now depends on the management of the local executive. Okay, so um, so this is one, and we can see that at this time of COVID pandemic thing. Okay, now let's go to the next slide. I would like to speak about the community. Okay, um, about the community participation in public health, engaging the communities for COVID-19 epidemic. You know, epidemic is a disaster. Okay, it is one. I mean, it's one of the hazards, and it's resulting to losses in lives and properties and income, etc., etc. And being in the field of disaster risk reduction and management, we actually have the National Disaster Risk Reduction and Management Council. Okay, but apparently the structure that was built up to take care of this disaster is the interagency task force. Okay, now I don't have, that's okay for me. But what is not okay for me is the lack of representation of civil society in this body. Because the Philippine Constitution itself says that the civil society should be participating in all government, services. And in this national team, the civil society is not represented. In fact, in the National Disaster Coordinating Council, National Disaster Risk Reduction and Management Council, we have NGOs. We have 4 civil society who are represented in the national agency. But now it's not represented there. Actually, the policy note 4 of the UP pandemic team speaks about addressing vulnerabilities. And we stated there the need for people's participation, the need for NGOs to be represented in the different levels of implementation of COVID-19. Not just implementation, but decision making itself. But apparently this is something that is not yet given that much response. Okay, so as I've said here, people are not victims, but they are also enablers. And they need to be, there's a need for empowering and engaging the communities for COVID-19 response and recovery. Participation in decision making in various levels, and there should be support for people's initiative. The communities can do a lot of support to our activities, including the contact tracing, even all those providing, ensuring the food distribution or food management in the communities. There are initiatives like that, and we should be encouraging that instead of terrorizing them, instead of preventing them from doing what they want to do, because this is their way. This is real. This is the true bayanihan. The true bayanihan is when the people themselves are acting, are doing something, are contributing their resources, their time, their energies, their talents, in order for them to be able to address some of the concerns of COVID-19. Of course, they cannot do those projections like what our experts are doing. Okay, they cannot do those testing. They cannot do all those other things. But we must be able to recognize the tasks, or the functions that they can really contribute. And at least if we don't recognize that, then they will not have opportunities to participate. There are several webinars and forums taking place. In one of the forums that we did was from risk to resilience, and this was about health options for a healthy society, which was held last May 19. And this was co-sponsored by the Philippine Academic Society for Climate Change, for Climate and Disaster Resilience, and the UP Resilience Institute is the secretariat of this. It was co-sponsored by Start Network also. And one of the speakers there, and I appreciate what he said, and this is Dr. Jos San Pedro. He said that there's a need really for community people. His topic was on community-based, on raising the bar with community-based health program. He said that if the capability of the health sector should not be flattened, no, it should not be, it should not be constant. It should be increasing as well. And the increase in that capacity of the health system can be done also if we allow people to participate, not just the communities, but the NGOs. There are so many NGOs which are specializing in health, and they should be motivated. They should be supported. But what's happening right now? There's some, because of the policies of checkpoints and so on and so forth, some non-governmental organizations trying to contribute towards addressing the needs of our communities are being stopped. Okay, and anyway, what we're saying is that there should be recognition and support for all people and communities and NGOs to participate in our COVID response. And then our next slide, and this will be my next slide. I would say that much of the public health condition is actually determined by the way we think, by the way we look at society, by the way we look at the public health system. And I have here just 4 points. Number one is this: health is multidimensional, rooted in the socio-cultural, economic, environmental, gender, political, spiritual aspect of human and society. It's not just about biology. It's not just about virus. The public is affected. The public health system is affected by all these factors. I need not go back. Okay. Secondly, and this is for me is problematic because um, because the poor will be the one that will be marginalized by this. And this is the commercialization of health services that perpetuate inequality. It is said that even if a vaccine, anti-COVID-19 vaccine is developed, the Philippines will be not given much opportunity to have that. And they said it's going to be very, very expensive. See? Why? Because the vaccine is considered as a commercial good. Okay, it's a commercial good that should be purchased. And who can purchase that? Only those people that have money. And among developing countries, or maybe, developing countries and even middle-income countries like the Philippines, if we don't have the money to produce and to buy those vaccines, then we will be the least to benefit from those development. Okay, so this is a problem. The problem about making public service a commercial product. I used to bring my Doctor of Social Development students annually to Vietnam. That is their field exposure. We bring them there for study tour. And one of our graduates who's a Vietnamese, one time I asked him, if a person will have an open heart surgery here, how much would a Vietnamese spend for that? You know what he said? I hope he told me the right figure, but he said maybe about $500. That's only about how much? 25,000 pesos. And I said, really? Anyway, maybe it's lower, but what I'm saying is that in the Philippines, if you're going to have heart surgery, it will cost you about 500,000 pesos. Okay? Sabi nga lang mahirap, mamamatay ako sa gutom, hindi dahil sa sakit ko. Mamamatay ako sa kaiisip kung saan ako kukuha ng pambayad ko. That's why a lot of poor people, instead of going to the hospital, they don't. Why? Because they're afraid of the money. They're afraid that they don't have money to pay. Yung mga patay na hindi pa nila mailabas eh. Okay? And that's our problem. That's our problem when we commercialize health services. Of course, I'm not saying that there's no role for the private hospitals. No, they can. But the point is, um, if the government would really make this as a priority, the public health service, then more people would be able to avail of good services from the government. Okay, the next one is, as I've said, related to number two, is about public health as a public service. Okay, so we would like to serve not because it's our job. It's not just because it is our job. It's not just because we like to gain profit. It's not because it will help us in our career development, but because we love the people. We have the heart. We have the kind of compassion for our people, and we would like to see that public health implementers would really see that, also with the private sectors. Okay, then lastly, I would like to say that health is a context as well as an instrument for social change. There are so many things that have to be changed in our public health system, and I mentioned that a while ago. But at the same time, it's not just the health system that has to be changed. I would rather say that even the health sector can be an element towards pursuing more relevant changes. Okay, because all aspects of society are interrelated, and we cannot isolate one sector. And we can push for the health sector to be an instrument for affecting change. I've seen this at the community level, where there are some community-based health program where some practices which were really oppressive among the poor were challenged by the alternative system of doing community-based health program. Okay, so that can be done even at the community level, where the community health providers do not, they don't get money for the services that they do, but the community are able to work on. Okay, so if this can be done at the community level, I'm sure that if we have proper perspective and proper ways of looking at all these things, and having more alternative in our thinking, then we will be able to have more relevant changes at the macro level with the health sector as a primary mover. So that's my last statement today. Thank you very much for this opportunity to really advocate for the Department of Health. Thank you so much.
Okay, thank you so much, Dr. Mel. Thank you for that presentation, for articulating the social impacts of COVID-19, especially how this affects, how this pandemic affects the vulnerable groups, especially the poor, and how important that we really look into the health sector to address all the concerns, the social issues that we are now facing in relation to COVID-19. So now let's move to the question for Dr. Mel. So for Dr. Mel, this is from Miss E.V. Castriciones from UP Diliman Chem. So is there an ongoing data information gathering on the effect of COVID on the poor population? Which percentage of the current COVID cases belong to the poor of the society per city in Metro Manila? So, Doc Mel, yeah.
We have as part of our projects in the UP COVID pandemic response team, I'm leading a research called assessment of the socio-economic impact of COVID in poor communities. Okay, so this cover both urban as well as rural. However, at present, the design is this: the actual data gathering at the community level will be done when we do not have quarantine anymore. We have to follow the rules of social distancing and following the rules of what can be done given the limits of the quarantine. However, what we're doing right now is that we have started gathering data on the impact of COVID-19 through social media, through the internet. So we already have review of literature. We have already gathered what's happening. We were monitoring reports in both social media and the televisions about events. And then from this data from the social media, we're going to do actual data gathering. Our area for Metro Manila is Quezon City, and our area for our rural, we have Laguna, and our partner in UP Los Baños said that they're going to get the town of, maybe premature, but they said it's going to be in Magdalena because they had very good quarantine system there. So we're now doing that study, um, and but so far as we can see, it's really the poor who was most affected. Yes, the middle class were affected also because they had businesses and now they don't have money to pay for the workers, and they're paying for the rents, they're paying for the capital outlay, etc. And so they're losing a lot. And but as I've said, it is the poor who are really affected so much. The next question is about, well, what's the follow-up question to that? What percentage?
Which percentage of
Which
the current COVID
percentage
cases
of the current?
belong to the poor of the society per city and Metro Manila? So do you have the data
I
to?
see. Actually, yeah, actually that we're trying to get, but apparently it's not included in the dashboards of the OH. Apparently, if you're a patient, you have to sign up an intake. There's only one indicator there that can show the socioeconomic status of the patient, and that is the occupation. Okay, the occupation, but there's no question about what income, etc., etc. And there's no data yet that collates and that makes it public as to the occupations of the patients affected by COVID. There are data. However, it's not public because of the data privacy law. Okay. However,
Okay.
if we can get that, then that would be good, provided that there's no mention of which patient. Okay, so we don't. But that's one thing that I've been looking for, because if we know the demographics of those who are having cases, those who died, who are recovering, then this will produce a very good output that can help us determine the social aspect of the COVID-19.
Okay, thank you, Doc Mel, for answering that. So now, the third and final question is for Dr. Mel. So, do you think it's high time for our legislators to revive the pandemic preparedness bill that the late Senator Miriam Defensor Santiago filed last 2013, or enact a similarly new bill which will be more of a long-term solution for potential or future outbreaks, rather than the Bayanihan Act, which is a short-term solution? So medyo, ano daw po yung palagay niyo, sir?
I do agree that there should be a long-term policy. There should be a long-term program for this kind of pandemic. This is the first time that I encountered this kind of pandemic, and we are really caught in the act. I mean, caught unaware of what to do. No, so a lot of learning was done because we were not familiar. However, if we have a law that, if you have a lot, there will be corresponding resources for that, and there would be more money for researchers for strategizing all these things. So I think that would require a law, and I would support that.
Okay, thank you, Sir Mel. I hope Leah Sernal, the one who asked that last question. I hope Sir Mel has answered your question. So I think this is when we would now end the webinar. So we would like to thank everyone who has joined us. So we have about 131 participants who are in this Zoom webinar. So we want to thank our speakers, Dr. Eric Tayag, Dr. Jomar Rabahante, and Dr. Mel Luna. We are very fortunate to have you for this science Science Forum. And of course, I would like to acknowledge our team from the Department of Science Communication, led by Assistant Professor Olga Lomboy and Ms. Char Orcaina. The rest of the team, Assistant Professors Mia Castillo, Gary Montemayor, and Avril Madrid. And I would also like to thank and acknowledge the assistance of Renz Rock for the live tweets that we have in our Twitter, in our CDC Twitter account, and Ton Lim for our video text. So I guess this is, don't worry, all your questions, we would gather all these questions and forward this to our guests, to our panelists. And also, we may remind you again that you will be receiving individual emails to the link of our an evaluation of this webinar. And after completing that evaluation, you will get the certificate for attending this webinar. At the same time, link and resources, copies of presentations of our panelists. So again, thank you very much for joining us and for staying with us throughout this almost 2 hours of discussion. So we hope that, you know that we are faced with this uncertainty, but we know that a multidisciplinary perspective, and as what our speakers have all been saying, that we work together, we work as one, then we will have all the solutions for this pandemic that we are facing. So again, thank you very much. So stay safe and
Salamat
healthy.
din.
Thank
Thank
you.
you.
So we will now be ending the meeting. Thank
Thank
you.
you so
Thank you,
much
Doc
Okay.
din.
Eric. Thank you,
Thank
Doc
you.
Mia, Doc
Salamat.
Jomar.
Tuloy
Thank you.
natin ang pamamatyag.
Yes,
Salamat.
pagmamatyag.